Welcome to Orthopedic Grand Rounds at the University of Washington. The topic this morning is Physeal, or growth plate injuries and pediatric fractures. I'm Chappie Conrad. I'll serve as the moderator. Our faculty is Dr. Ted Sousa, one of our chief residents, Dr. Mark Dales, one of our pediatric faculty, and Dr. Antoinette Lindberg. Dr. Sousa will begin us on some of the basics and a general view of pediatric fractures and growth plate injuries. Ted?
Thanks. So I'll talk about the basic science and the classification of growth plate injuries. Some people are visual learners. I am one. So if you can look at this, you can memorize the Salter-Harris classification and how it's broken down. We'll go through that in a little bit. Childhood fractures are pretty common, actually. 50% of boys in their childhood and 33% of girls will sustain a fracture in their life. The physis is involved in 18 to 30% of these fractures. This is 2.8 per 1,000 person years. There's an interesting study that was done recently that's basically looking at who is fixing these fractures. It was done by the group in LA. 10 years ago, they did a study where they called up 50 orthopedic practices and asked the question, my 10-year-old son broke his arm on vacation last week, and I was told that I need to follow up in your clinic within a week. And what they found, and what they added the question was, which of these private practices around the city of LA would give them an appointment within 1 week? 10 years ago, 100% of those children that were privately insured were seen in a timely manner, whereas those 2% with Medicaid were, which points out the great disparities in fracture care and the pediatric care. They then redid this study 10 years later, and basically it's saying a major drop-off in the number of kind of private practice orthopedists who would take care of children. So it's likely multifactorial of why these physicians aren't seeing them, but I think one of the main reasons is the trend towards specialization within the orthopedic practice. The American Academy of Orthopedic Surgery in 2008 did a survey looking at basically asking, do you see yourself as a specialized or a general orthopedist? 46% of orthopedists noted they were specialists, and of the age group from 30 to 39, the one that I belong, 58% said they were specialists. Only 7% of orthopedists identified themselves as pediatric orthopedists, with 6.5% under 40. There's a shift towards operative care, towards the pediatric orthopedic specialist for the operative care of pediatric fractures. This is felt due to decreased complications, decreased hospital length of stay, and there's some thought that maybe there's decreased complications. However, there's also increased cost. Families have to often travel long distances to see the pediatric specialists. This is time away from school, time that families need to find daycare for other children, and also it can delay treatment, as we pointed out in this study. So the goals of this study are just basically to kind of demystify the physis. I think there's a lot of specialists out there that say, you know, I don't know, there could be limb length discrepancies with this child. Let's just boot him to Children's Hospital and they can take care of him. And really, I think what we're going to talk about today is that, you know, I don't think it's as complicated as everybody makes it out to be. So I'm going to talk about the anatomy of the physis. I'm going to do some classification of physeal injury, talk about the epidemiology of physeal injuries, and then kind of talk a little bit about growth disturbance, but I'm going to leave that mostly to Dr. Dales. So what's the physis? Well, the physis is the growth plate. It's a cartilage structure at the ends of each of the bone that contribute to bone length. These physes close anywhere in girls between the age of 14 and 16 and boys to 16 to 18. However, there's physes such as the clavicle which close much later, like age 25. Importantly, it's the weakest portion of the bone often. The growth plate is supplied by basically three main blood vessels: the epiphyseal or epiphyseal vessels, the periarticular arcade, as well as the metaphyseal vessels. So I think when most orthopedists see this slide, they kind of want to puke a little bit. Histology is a little complicated, but it's tested a lot on our exams, and so I think it's important to know. There's basically multiple zones of the physis. And first, I'll just talk about a little bit about the vessels, since I just brought it up in the previous slide. So the kind of epiphyseal vessels come through what would be the top of this slide and work their way down, and then the metaphyseal vessels are coming up. They pass through the resting zone. In the resting zone, there are basically, it's a hot area of a thick matrix of type 2 collagen with a sporadic cellular population. It has a lower oxygen tension as the vessels are passing through this area. The proliferative zone is where the vessels end from the epiphyseal vessels, and this is where a majority of the longitudinal growth occurs. And you can see that the cartilage and the cells in this area are lined up like skyscrapers. The collagen becomes more non-uniform in this area. It's where aerobic metabolism takes place, and where there's production of proteins that contribute to growth. In the hypertrophic zone, there's an upper and a lower zone. And basically what's happening is these cells are growing as they're producing a lot of proteins that are going to go out and cleave the collagen, the type 2 collagen. And as they also do that, they cleave a material called aggrecan, which is an inhibitor of calcium formation. So as we inhibit calcium, of course, we go down to the kind of the ossification zone where calcium homeostasis takes place. Basic mitochondrial transporting from the lysosomes the calcium out of the cells and into the matrix, and we start getting calcification. It's important that the hypertrophic zone is relatively avascular. You have the epiphyseal vessels coming from above and the metaphyseal vessels coming from below. It's kind of for testing purposes. Remember, this is where kind of glycolysis and ATP is taking place. So hopefully that helps. This is one of those slides that's also there that looks at kind of different diseases that are associated with this disease. As you know, MPS disorders are due to the lysosomes, so you can think about that. People that are short or very tall, like achondroplastics and giants, they're going to have problems with their proliferative zone, etc. So just know that this is something you should look at. When we look at the contribution of each physis to the long bones, it's different, proximal and distal. And it's broken up, and you can try to memorize a slide like this, but I think it's better to try to think of a slide like this. Now, if you're preparing a talk and you're looking up people in tubs, I would not recommend that you do that with children present, because you can get some interesting photos. But I think try to think of this image maybe down below. It's more rated G. So the bones that are above the water are the fastest growing bones, fastest growing part of the bones, while those below the water are the slower growing part of the bones. And so it's kind of a way to think about it in your head. Growth by year. So at Children's Hospital, Dr. Mosca teaches us the kind of rule 3963, where you think about moving from the proximal femur to the distal tibia. Except I was not able to find an exact picture that said this. So I think depending on the study, but it's kind of rough estimates. And this is important when you think about growth disturbances and how much each area is going to grow. So the Salter-Harris classification system was developed in 1963 by two gentlemen. It was based on a mechanism of injury and the relationship of the fracture line to the layers of the physis. There is also a prognosis with respect to the growth disturbance. So a Salter-Harris type 1 injury is an injury straight through the zone of hypertrophic cells. It separates the epiphysis from the physis. Growth is usually undisturbed unless the blood supply is involved, and it's most common in young children and has a favorable prognosis. Type 2 injuries are also through the hypertrophic zone, but have this metaphyseal Thurston-Holland fragment that is also present on the compression side of the fracture. The periosteum also remains intact on this side. Growth disturbance is also rare, as it does not go through the germinal side of the physis, and it is the most common type of Salter-Harris fracture. Type 3 fractures are those that are through the epiphysis. They're intra-articular injuries. They often require an open reduction to make sure that the joint is aligned. They're more common in older children, and given that it's involved the joint, their prognosis is less favorable. Salter-Harris type 4 are through the epiphysis and the metaphysis. These require both an anatomic reduction of the physis as well as the epiphysis, And this is where osseous bridging can occur, as there can be a connection that forms between those two areas. And of course, this is a less favorable prognosis. Salter-Harris type 5 injuries are a compression or crushing injury to the physis. It's rare, it's difficult to impossible to diagnose, and it lacks the typical radiographic signs of a fracture, and it's usually diagnosed much later with a growth disturbance. The demographics of physeal fractures, the peak age is between 13 and 14 in boys and 11 to 12 in girls, which is important to think about because children are ending their growth at this period. They're twice as common in boys as girls, but as girls are involved in more sports, they are becoming more common. 15 to 30% of long bone fractures involve the physis. The most common areas are the phalanges, distal radius, as you can see there, and upper limbs more than lower. Growth disturbance following these injuries is very rare. It's only 1 to 10%. It's usually apparent within 2 to 6 months after the injury, but it may take a year to identify clinically. Peterson classified these with a type 1 being a peripheral injury. It can be problematic because it can create an angular deformity, but it can be easily accessed surgically. Type 2 are the elongated or linear or longitudinal bars. As you can imagine, this is from a Salter-Harris type 4 injury, or perhaps a 3. And then there's the central ones, which can occur from a Salter-Harris 5. What can end up happening is the physis gets tinted, so does the articular cartilage. Growth arrest basically occurs when there is a contact between the epiphysis and metaphysis. In 1988, Makela did a study where he sectioned rabbit physes and found that basically we had to have more than 7% of the physis to be damaged to form a permanent bridge. All Salter-Harris types are associated with arrest, although we've pointed out the higher types are more likely. When you look at this type here, a malunited, 60% can lead to arrest. Some physes are more vulnerable. The distal femur has a reported rate of 50% in physeal bridges. And this is because of the flat versus the undulating physes that the distal femur has. I'll let Dr. Dales go into complications of physeal arrest, but just for start thinking about is you can end up with limb length discrepancies if the complete physis is involved, or angular deformity if it's partial or a tether. This can lead to loss of function and deformity and disability. I'll now turn it over to Dr. Lindberg, who will come and talk about the acute management of physeal injuries.
So obviously 10-15 minutes is not enough time to go over treatment of every single type of physeal fracture, but what I want to kind of get through here is just a few general principles about how you want to treat these, and then some pearls for certain common physeal fractures. So the overall goals of acute management are fairly simple. Number one is no different from adult fracture treatment. You want to restore the articular surface. You don't want any step off, as that can cause long-term problems with degenerative changes in the joint. The second part is you'd like to realign the physis as best as you can, and this will help prevent either the partial or complete growth arrests down the road. In terms of whether you want to do open or closed reductions, it's preferable to do a closed reduction whenever is possible, but the important thing is this is not where trying more to get it perfect is the ideal situation. You want to give one good attempt and really minimize any extra attempts, because you don't want to injure the physis further with repeated manipulation. And sometimes you can't help it, you have to do an open reduction. A lot of cases where you can't get a good reduction, you may have trapped periosteum in the fracture fragment, and ultimately you still need to restore the articular surface, so that may require open reduction. And of course, anytime you have to do this, that does increase your risk of arrest. So general principles of fixation when you need to do it. First of all, you don't want to cross the physis unless you really have to. And if you do, smooth pins are preferable. There are some exceptions in proximal femur and for Tillot fractures. And if you do put screws in the epiphysis, like that ankle in the bottom corner, you do want to ultimately remove them once the fracture is healed so that you maintain normal pressures within the cartilage. So distal radius physeal fractures, one of the most common ones we see. The displaced type 1 and 2 fractures usually do really well with just closed reduction and casting. You don't even have to get them that perfect because the younger patients have a ton of remodeling of this area. Older patients don't tolerate the angulation as much, but you're also less concerned if you do have an arrest. So you can probably, this is one where you can probably give a couple attempts and squish up the physis a little bit without too much problem. You do need to consider an open reduction if you cannot get your stable reduction closed. And percutaneous pins might be necessary with your reduction if you find that it's just not stable enough. In terms of the Salter 3 and 4 fractures of the distal radius, you do, again, have to align your articular surface as well as possible. So in the proximal humerus, most of these fractures can be treated conservatively. There's so much remodeling potential at this physis, and also the shoulder range of motion that's normal has a huge range that can really compensate for quite a lot of angulation. And just as an example, this is one patient that was treated at our hospital where you start out, it's actually not even the worst amount of angulation I've seen, but over the course of 9 months, there's a tremendous amount of remodeling that you can see. There's all sorts of different kinds of mobilization you can use. You can do shoulder mobilizers. I've used the old-fashioned hanging arm cast, which ironically doesn't cover any part of the fracture at all. But sometimes for some very displaced fractures or older patients, you can consider percutaneous pinning to keep everything in place. The distal humerus, the transphyseal separation, although it's not that common, is overrepresented in test questions. So this is the one where you are told that there's a infant or really young toddler with a, quote, elbow dislocation. So children that young do not get elbow dislocations because the physis is far weaker than a lot of the soft tissue. So what happens is they have a transphyseal fracture that's displaced, but you don't see the rest of the cartilage that's attached to the forearm. So these are treated with a closed reduction and pinning, similar to supracondylar humerus fractures. But the important thing to know about this is even though it can happen with routine trauma, there's a slightly higher association with non-accidental trauma. For proximal femur, the physeal fractures are the Delbey type 1 fractures, and they're fairly rare. They're probably less than 10% of all pediatric hip fractures, and they usually come from pretty high energy trauma. And then there's also the unstable skiffy, and skiffy is an entirely different talk in of itself, but just remember that is basically where you have an acute on chronic process and can occur with much lower energy trauma. So the really important thing for proximal femurs is you want to do as urgent of a closed reduction as you can to decrease your AVN risk for the hip. But with that in mind, a large portion of that osteonecrosis risk comes from the injury when it occurred itself. So you know, even if you get the most expedient reduction, it may not completely take that risk away. If you cannot get it closed reduced, you do want to do an open reduction in this case. And this is the one of the exceptions to the screws crossing the physis rule. In this case, you have to have a stable fixation, even at the expense of whatever happens to the physis. So these are usually best fixed with some sort of transphyseal screw, and you often need to back this up with a spica cast as well. The other important thing is similar to unstable skiffy, you do want to do some sort of decompression of the hemarthrosis in the joint, again, to decrease the pressure within there to try to decrease your AVN risk. Distal femur, if you look at a lot of old literature, they talk about stress views. I challenge you to find a single ER or parent that will let you do a stress view on a distal femur. So it's really not practical at this point, and you have to, you know, do a really good exam and consider some alternate imaging if you really think that's a problem. For non-displaced fractures and many of the Salter-Harris 2 types, you can probably treat them conservatively with closed reduction and casting. However, Salter 1 and Salter 3 fractures that are displaced may need some cross pinning with smooth pins. Important thing to kind of keep in mind, if you do have to cross pin, you want to go proximal to distal and not the other way around, because if you're going from bottom up, you have a very high chance of having those pins cross through the joint, and therefore you're leaving people with a setup of having a septic joint as a complication. And regardless of whether you use screws or pins, given where these fractures are, it's probably wise to throw a cast on top of it to give a little bit of added immobilization other than the hardware. True proximal tibia physeal fractures are rare because most of that physis is within the joint capsule, but there are other types of fractures, such as a tibial tubercle fracture, which involves fracture through the apophyseal fragment. And these come from eccentric contractions of the quadriceps, and they can be isolated to the tubercle, or they can extend more proximally into the physis. And in about 20% of these cases, the patients will have some sort of Osgood-Schlatter type symptoms that predate the injury itself. For non-displaced fractures like of the tibial tubercle, you can cast them in extension, but the more displaced fractures or intra-articular ones do require open reduction internal fixation. And the important thing about these fractures is there is a known risk of anterior compartment syndrome due to the recurrent tibial artery. And so a lot of times we talk about doing a prophylactic fasciotomy at time of open reduction. In the distal tibia, Salter-Harris 1 and 2 types have the lowest risk of having a growth arrest. And 40% of these types of fractures are Salter-Harris 2. You can usually do a closed reduction, and if you're having difficulty keeping that reduction, you can do a lag screw that goes through the Thurston-Holland fragment if you need. Triplane and Tillot fractures are a specific subset of these distal tibia fractures, and these are called transitional fractures because they happen really close to when patients have their physes closed and they reach skeletal maturity. The triplane happens in slightly earlier age and involves a big posterior metaphyseal fragment, whereas the Tillots are only that small anterior lateral fragment in the distal epiphysis. For these fractures, I think it is always worth trying a closed reduction, and what I like to do is you do your closed reduction maneuver, and then instead of getting post-reduction x-rays, go do a CT scan. That way, if your articular surface lines up, you're already in your mobilization. Sometimes people would do the CT scan before, but then you kind of won't know after your reduction whether you have the joint lined up unless you do another CT. So anything that has more than a 2 millimeter step-up or gap should probably get surgery to get it aligned up more perfectly. And in the case of a Tillot fracture, like the bottom x-ray, you can consider doing a transphyseal screw because those kids are essentially almost done with their skeletal growth. So that was the last part of their distal tibia physis to fuse, and you could just skip and make sure you do it ahead of time for them. So that pretty much summarizes just a quick review of all the common physeal fractures, and then I'll let Mark Dale go into talking about some of the problems when the healing is not as smooth and straightforward.
I'm going to talk a little bit about the later effects of physeal injury. As we all know, for the most part, the physis is our friend. Fractures that don't involve the physis and many fractures that do involve the physis provides ample remodeling and allows us to treat many children in a less aggressive way with less invasiveness than adult counterparts. And so most of the time our friend. But anytime you have an injury to the physis, there's at least a potential for having a growth disturbance, which can lead to progressive deformity and limb length discrepancies. The physeal arrest and growth disturbance kind of come in two basic types. You can either have a complete or near complete arrest, in which your really only problem is a potential limb length discrepancy developing over time. It can also be a partial arrest where the remainder of the physis is still functioning, and so the arrest remains as a tether to normal growth, and that can produce either shortening or angular deformity or a combination of both of them. Basically, the principle is to identify these disturbances early so that you can deal with them simply as a developing arrest and not have to deal with a problem that's already become the arrest plus a significant deformity over time. The management ends up getting determined by extent of the physeal bar, the location within the physis, The particular physis, as demonstrated by Dr. Sousa a little bit earlier, and the amount of growth remaining for that particular patient. When we look at the extent, often standard radiography gives us a reasonably good idea initially of how much of the physis is involved. Plain films are also the best way to kind of check the general alignment of the extremity to see where the deformity situation is. Tomography is kind of a historical note at this point, but was what was originally used to map these out three-dimensionally to get a cross-sectional idea of the area. That's been supplanted by CT scan and MRI now. The CT scans can give you very good visualization of the bony bar, but it really doesn't give you a too good idea what the remainder of the physis is doing from a health standpoint and potential growth. They're quick, and so they have the advantage of being able to be done on a young child without sedation. But the MRI is becoming increasingly the sort of the gold standard. It gives excellent visualization of the physis. There's no radiation involved. You can not only see an anatomic bony bar, but you can determine if the physis itself appears somewhat sick looking, which may alter your approach over time. If you're into specifically identifying it, the fat-suppressed, three-dimensional, spoiled gradient echo imaging, as first described by Eklund and Jaramillo, provides the best visualization. Both CT and MRI software is available now that will map this out and determine the cross-sectional areas very nicely, so you can make your cross-sectional determinations. It does take longer, though, and for the younger children, it's going to necessitate a sedation. Dr. Sousa kind of reviewed the location of the physis nicely, and I won't really dwell on that. Growth remaining can be determined by a number of different methods, which kind of goes beyond the scope of this discussion. But from a practicality standpoint, the good old left-hand AP and using the images to compare the Grurok-Pyle axis works very well when you're making kind of an assessment of these type of patients. And again, you just remember that in general, the boys have most meaningful growth done by a skeletal age, bone age of 16 or so, and girls by 14. These, again, are the sort of a different way of looking at the numbers that Ted showed of the individual average growth of the physes by millimeters. I might add that probably a corollary to his admonition is that you especially don't want to look up children in bathtubs on the internet when you're searching this out. You can kind of see here that, as Dr. Lindberg pointed out, here's a proximal humerus, which has 2 to 3 times the growth of any of the other major physes here, which accounts for its significant remodeling potential. So considerations when you first see a child with potential for a growth disturbance after a physeal injury is the effect that's already present, and that's going to obviously be shortening and deformity. At that point, you have to determine with remaining growth what further shortening may occur and what further deformity may occur. Sort of a special situation is when you have a two-joint complex, such as the wrist or the ankle, because those joints are very sensitive anatomically to differences in the normal anatomic relationship. So relatively small growth arrests in those areas can have fairly significant impact on the long-term function and health of that joint, which might not be of any consequence at all if it's just simply longitudinal growth. So we have 3 basic treatment options. We can observe, we can complete a partial arrest, or we can get into the attempted resection of a bar, of a partial bar. Observation is appropriate when the bar or damaged area involves most of the physis. This is often scenarios in other reasons for growth arrest, such as infection. But with trauma, as again was pointed out earlier, a lot of these injuries do occur when the kids are really kind of getting into the teen years and may have only a year or 2 of growth remaining, and in that case, it just may not be an issue. Obviously, the leg length has to be acceptable, both at the time you're seeing the initial evaluation as well as the potential for the future. There should be very little, if any, deformity and little remaining growth to cause further problems down the line. More commonly, we're considering completion of a partial arrest. And again, in this situation, the deformity has to be acceptable. There can't be an excessive amount of angulation. The bar is going to be too large to be realistically considered for resection, and the predicted length discrepancy is going to be unacceptable over time. And once again, you have to kind of recall that we have the scenarios where you have two bones, and if we have a partial arrest here or a complete arrest, this ulna is going to keep growing and give you a positive ulnar variance that may not be acceptable. So the answer may be simply stop the growth here and keep that static, and then stop that as well to make sure that that doesn't disproportionately grow. If the limb length discrepancy is going to be roughly between about 1.5 centimeters and 4 to 5 centimeters, then it's probably appropriate to arrest the contralateral side and keep the situation static. If you're kind of late to the game in seeing the child and they're already kind of heading to the higher levels of that, 4 or 5 centimeters, then it may be appropriate to add another physis on the uninvolved side to do a little catch-up. If the limb length discrepancy is going to be greater than 4 or 5 centimeters, so again, this is usually going to be the young children that unfortunately have an injury, then it's really going to come down to doing either ipsilateral lengthening, which again is sort of beyond the scope of this discussion, or a combination of ipsilateral lengthening and a contralateral time to epiphysiodesis and the more extreme variations. When it comes down to consideration of resection of a bar, several things have to be considered. You have to have significant growth remaining to make this work. There has to be either currently or the potential for significant deformity developing, and it has to be a relatively discrete area of the physis that is amenable to being resected. This was first introduced by Langenskold back in the late 60s. He first reported in 67 and then followed that up with a larger series with some follow-up in 1975, and there's been multiple series since then. The principle is basically resect the bony bar and possibly some of the damaged area around it to what is termed healthy physis. Fill that void with a material that will prevent reformation of a bar and allow the remaining physis to resume growth and possibly some remodeling of deformities there. So again, if you're going to try to resect these, the remaining physis surrounding this relatively discrete area has to be healthy. The remaining physis has to be large enough to succeed with continued growth and possibly remodeling. And there has to be enough general growth left in the patient themselves to warrant the attempt. So how much is enough? Essentially, all the series have demonstrated that the results can be anticipated as being poor if the bar is greater than 50%. There's isolated reports of success with the larger ones, but in general, most reliably, you're going to get a good result with a 20 to 25% of the total cross-sectional area. The wild card in all this may be that we tend to focus on the cross-sectional area of the visualized bony bar, but often the perimeter area of the physis may be what, again, we call sick physis and may really not be have the potential for normal growth. How much growth needs to be remaining? Again, different people have said slightly different things over the years, but in general, kind of the rule of thumb we use currently is 2 years of growth remaining. Kasser felt that, especially in the distal femur, should probably have 2.5 centimeters of growth available to make this a worthwhile endeavor. And then deformity has to be considered, and the choices are remodeling versus a corrective osteotomy done acutely. Remodeling has certainly been documented, but without a doubt, as most of the series have shown, early improvements also often followed by a loss of correction as time goes by. And kind of conceptually, it makes sense that looking at the Hutter-Volkmann principle, what you want to do is unload this damaged area where you've just resected a physeal bar. You're expecting the surrounding physis to do good work, and getting excess pressure off of that makes some amount of sense. So 35 degrees has been reported anecdotally in papers, but in general, once again, 15 to 20 degrees is probably kind of considered the outside maximum, and 10 degrees may be more a realistic number when you're looking at this and trying to decide remodeling versus an acute osteotomy. If you're trying to resect a larger bar, bigger than 25% of the cross-sectional area, you probably ought to really not accept any significant angulation with those. So going through the surgical technique briefly for these various types, the peripheral ones are the easiest to get at, obviously, although they don't necessarily have the best long-term results. It's generally a direct approach directly over the area after it's been identified, mapped out. The periosteum is elevated, but it's important to remember you resect this periosteum. You do not want to repair it, otherwise you're just inviting a perimeter bar to reform again. What I like to do is visualize normal physis at least on one side of the bar, and then from there work with a high-speed burr and just slowly remove bone until you see a perimeter of good, thick, healthy-looking physis along. And again, you have to kind of watch out for being fooled, because you'll run into physis sometimes early on that's kind of narrow and not that good, and you need to keep going until you get to the thick stuff that looks healthy. And then you fill the defect, and you're done. The challenge with the peripheral ones is that filling that defect, it's right on the defect. You don't have periosteum to close over the top of it, so keeping it there can be a challenge. So you often have to suture it into the epiphysis to keep it there. So again, approaching it from the periphery, making your void to healthy physis, and then filling that with interpositional material, which we'll talk about in a second. For the elongated type B type, as you kind of might guess, it's sort of a hybrid, so it can be approached in two ways. You can either do a peripheral approach, like for a peripheral thing, and then just extend that more deeply as you go across the width of the epiphysis, or you can do a metaphyseal osteotomy and open up the metaphysis and come directly from above on it. The central ones actually have the best long-term results when you look at these in the series, but they're also technically the most difficult to do. You can approach these basically in three ways. You can either make a metaphyseal window and then develop a tunnel down to the bar and resect the bar and put your interpositional material in. You can do a metaphyseal osteotomy and again open that up and approach the bar from the metaphyseal bone above. Or you can use a modification described by Jackson, which is illustrated here, where you just pre-plan a wedge of metaphyseal bone, pre-drill and pre-tap it, remove that, and again approach it through the metaphyseal bone without making a complete osteotomy. And again, this is obviously appropriate if you don't have deformity that you need to correct. So using a metaphyseal window and a tunnel, excellent 3D planning is needed. You really have to kind of map these out, and including good osseous landmarks so that you have a reference point when you're going in. You make your window, you got to make it large enough to actually work through. Using a C-arm, you usually kind of get down to the area of the bar, either directly using a curette, or I've used a guide pin followed by a big 10 millimeter ACL cannulated drill. Use your high-speed burr once again to remove the bone. Usually the bar is kind of more cortical-like bone and hard compared to the surrounding softer cancellous bone. That can help you identify it too. Once again, once you've gotten the bar resected, you fill it with interpositional material, then you gently put the metaphyseal bone back in and you replace your window. Some people recommend on these bar resections that you should leave a little bit of the physis proud, so you undermine both the epiphyseal and the metaphyseal sides with the burr so that the physis sticks out just a little bit to prevent these perimeter spot welds from reoccurring. So again, sort of metaphyseal window, approaching that, doing a circumferential bar resection until healthy physis is seen, filling it with interpositional material, and then finally the graft or the original cancellous bone in the metaphyseal window. Here's the challenge with it in the lower left here, is that actually seeing the physis down this deep dark hole can be a real problem. So in reading and looking at this, it looks difficult. It turns out that it actually is more difficult than it looks. Some of the things that have been developed over time to aid in visualization are the use, obviously, again, of C-arm fluoro to do your initial macro localization. I like the lighted sucker tips for actually both the peripheral and the central ones to remove sort of blood and debris and be able to light down that corner. Dental mirrors have been historically used and still are used to be able to circumferentially look around circumferentially once you're down in there. Microscopes have been described as it takes binocular vision and allows you to look down a deep dark hole with a sharp image, just like for microdiscectomy. More recently, the use of an arthroscope or a osteoscope, as described by our own Dr. Smalley recently in a case report, has been used, and a couple of series have come out using this with good results where you can't use the scope and burr at the same time, but you can just basically keep going back and forth between the two, and the scope does provide the magnification, light, and lighting and irrigation to allow you to get a pretty good look. An osteotomy is a good choice if you already have a deformity that's unacceptable, obviously. Once again, these are harder than it looks from the line drawings in the book, where it seems you just make a bone cut through the metaphysis, you open it up like a big book, go down right on top of it, and then take out this bar. The problem is the soft tissues, the periosteal, neurovascular structures, and whatnot keep you from doing this to any great degree. So what you really end up is a metaphyseal osteotomy and being able to open it up just a little bit, even if you're taking out a closing wedge osteotomy for correction, and it's still pretty hard to see in there, keep the field dry and all. But it is something, especially if you have a significant deformity to correct, that can be considered. More recently, we've used what we call guided growth to correct a lot of angular deformity in kids, and this can be used to some degree in the more modest deformities in this as well, where this is an example of a child that developed a very, very small peripheral injury here. Almost looks like an adolescent blounce, but he had a discrete trauma history to it. Did a peripheral resection medially of the bar and then placed these little Physeal plates that we use for that. And this is about a year now post-op, and you can see he's gradually correcting. But this is a fairly modest deformity to begin with, so you'd expect a reasonable chance of success with that. For interpositional material, there's been a lot of things tried over time. The two most common by far have been autogenous fat or cranioplast, which is just PMMA without the barium in it, so as it sets, it doesn't generate heat. You obviously don't want to kill the surrounding physis. Now, even more commonly, autogenous fat is used. Silicone's been used in the past, but is not commercially available for this. People have worked with transplanting both cartilage as well as chondrocytes, which I may mention in a minute. And there's a recent report using fibrin glue to use as an interpositional material with pretty good success. Again, autogenous fat is the most common. It can be either obtained locally or at times through a separate incision if you need a little bit more than is available locally. It has a disadvantage not providing any structural support, but most of the time you really don't need that. You have to, again, remember to anchor it to the epiphysis so it doesn't migrate into the metaphysis and allow a new bar to form. And there's the problem that the hematoma that forms postoperatively tends to try to displace this, so you really do have to attach it so it doesn't just go floating off. And again, just a reminder, don't suture the periosteum over the peripheral ones. It's fine to suture the periosteum, obviously, over a metaphyseal window, but not the peripheral resections. Most people leave little metal markers on both the epiphyseal and metaphyseal sides to monitor growth after you're done. And here again, here's a Salter II ankle fracture that was treated elsewhere. Maybe not exactly how I would have done that, but certainly an acceptable reduction. Went on to get sort of an elongated type of physeal bar. Did a resection from a peripheral approach. Left these little two markers in. This is about 3.5, almost 4 years post-op on that. And you can see had reasonable growth and a little bit of, probably a little bit of varus deformity, but not too bad. I'm doing well. So the various studies through the years have kind of been remarkably similar. Most of them are kind of showing roughly kind of in the 70, 75% good to excellent result range. The series here, Williamson and Staley from Seattle Children's Hospital back in 1990, again, was consistent with all that. They used fairly rigid criteria when they put their study together and did well. One of the things you can kind of notice that a number of these studies also show that a significant number of these patients will end up with secondary procedures to really get things optimized by the time it's all said and done. So very rarely is this a one-time thing. This is the one series by Marsh with using an arthroscope. And again, not really better results than anybody, but maybe a little bit better to visualize. So overall, I think we can say that when we say successful resection, what we're really implying is that we're probably going to have a decreased growth compared to the contralateral side. We're going to maybe have some modest ability to correct deformity through remodeling, but otherwise we're going to need an osteotomy to correct it. The physis is probably still going to close earlier than normal, even if it shows good initial growth following the resection of the bar. And the frequency of secondary procedures is very high. A lot of this is probably due to the fact that the, again, quote, healthy physis adjacent to the bar is really not so healthy. Realistically, when you do these resections, you end up with resecting more bone than just your bar that you three-dimensionally planned ahead of time. And so the area probably is a little larger. Even though your bar appears radiographically to still be free on follow-up x-rays, you probably do have spot welds along the perimeter. We talked about Hutter-Volkmann principle maybe affecting the residual growth. And basically, there's increasing stress on a fairly limited amount of remaining physis. There's a few novel approaches that in the interest of time, I won't go into too much here. Epiphysiolysis has been tried with this to break through the bar and correct deformity acutely. The problem is that usually after epiphysiolysis is done with external fixation and distraction force, the physis closes early. So you kind of lose your original gain. Physeal transplant from apophysis and other areas has been used for some animal studies with some success. Cultured chondrocyte interposition has been used in animal studies, and again with some fairly good preliminary results with that. I was not able to find a series with human implantation, but microscopically some of these line up in columnar fashion just like a regular physis over time. And then finally, like a lot of things, gene therapy, tissue engineering may be the answer to the future with what's now kind of a mechanical thing. So a couple, again, studies that have been done with animals showing sort of potential for some of these biologic manipulations. So in summary, I think for sort of all of us, can say that physeal injuries always come with some potential for limb length discrepancy or deformity. The parents need to be advised this from the onset. You look smart if you say something right from the start. You don't look so smart if it happens after the fact and the parents are surprised by it. They need to be closely monitored. You want to find these bars early. You don't always necessarily intervene surgically early because some of these will lyse themselves over time, but you want to be watching them carefully so that you don't end up in a situation where they have a big deformity. Once you do identify them, you want to start your planning. You want to make your predictions, and you want to know where things are potentially going so you can treat this in the simplest way. You want to choose the least invasive way of managing it to achieve ultimately normal function. And basically, physeal bar resection has a role, but often results with incomplete correction, and secondary procedures really should be anticipated and counseled when talking with the family. The anatomy of the physis is straightforward overall, as reviewed by Dr. Sousa. The injuries are common. The amount of times that the injuries result in a physeal disturbances are relatively rare, as mentioned, really only somewhere between 1% and 10% overall, but some of the physes are definitely prone to a higher percentage, like the distal femur, proximal tibia. By and large, these are areas where, although, as Dr. Sousa mentioned, more and more pediatric injuries in general are being pushed to the pediatric facilities when they maybe don't need to be. This is one area where the pediatric orthopedic specialists in the hospitals probably should be managing most of these. So that's about it. Thank you.